There are quite a few delivery system and platforms for delivering medication to COPD and asthma patients. Obviously, we are used to the metered dose inhaler, but even with that push and inhale type of delivery system, the metered dose inhaler, now there are some renovations in improving its efficacy and delivery system. So that's one. That delivers aerosols, but it involves about 9 steps in using it. The second platform is a dry powder inhaler, and there are multiple devices that deliver the medication in a dry powder formulation. Some of them are single dose type of devices where it involves putting a capsule and pushing and inhaling. Others are multi-dose devices, but that involves the patient to take a deep breath in to deliver the dose of medication. The third platform is what we call soft mist inhaler, or SMI. And that is almost like a micronebulizer. Unfortunately, we only have one delivery system right now that is in that platform. And then the fourth, of course, important is a nebulization platform, which is something that we've been using for a long time. It does really not involve patients' active performance. It's really a passive delivery system. So these are the 4 that we have right now. Yeah, recent guidelines for measurement of asthma COPD emphasize the need for checking inhaler technique in the clinic as part of the management strategy. And actually, this is something that has been added to the recommendations for both asthma and COPD. The fact is that not all patients master all techniques similarly, and certain devices may be more suitable to one patient compared to another. So I think there should be a shared decision making capability between the patient and the clinician as the choice of inhaler device. But also, it's not a one-time deal. This has to be done on a repeated basis. And the best way to do it is to show the patient how to use it, not just to give them a pamphlet or just depend on our colleagues in pharmacy to do so. So I think it's something that we've been emphasizing on, but also now the guidelines have to. Well, I mean, I think the physical ability of the patient, the ability to perform in a good inspiratory maneuver, particularly if you're choosing a dry powder inhaler or DPI, patients have to be able to have a good peak inspiratory force. You can actually measure that in the clinic. So what we call PIFR or PIFR is something that has been studied more recently in several publications, showed that those with patients with low PIFR don't do well with dry powder inhalers. Similarly, patients with physical disabilities or like extremes of age may have problems with the metered dose inhaler because it does involve several steps. And so these are factors need to be considered. Of course, cost is an issue, and some devices may cost more or less, so that's another issue, but we won't talk about it in more detail. That's important. Some patients maybe don't want a taste of dry powder in their mouth, so I think patient preference, if there are choices, sometimes we don't, but if there are choices, the patient preference should be also sought in discussing the devices. I feel like nebulization, for example, may be suitable for people with physical or cognitive dysfunction, like severe elderly and those with memory loss. They may not perform well with other devices, and maybe a passive type of delivery like nebulization may be the choice for that type of patients.